Hi everyone. Good evening.
Good evening.
Thank
Good
you.
evening, sister.
Thank you, my dear.
Good
So
evening, sister.
another evening for surgery. Today we are going to discuss burns. I'm hoping that we'll get time and add on the wound coverage, which is not so much. So let's please the refs try your best and time me. When is an hour into the lecture? If I'm not done, I speed up so we can finish up. That's two lessons for the day. All right, thank you very much. Burns. I'm sure that we've all nursed burns before. If not, we've all had it one or the other before, or maybe we've also seen a friend, a colleague had burns before. What really is it? And then by kind courtesy also, I know that I have some few of my colleagues I had worked with in CAT who are burn specialists and they are here with us. And so I'm sure if there's anything, they would have a bit of additions to our lectures. Whoever also is here who have had, and you see burns is a specialty area. And so whoever had have a bit of experience with that, you can add on a bit of contributions during our lecture. And then thankfully also within my area of schooling now, that is my research interest. And so I've had a bit of readings in that area in Benz as well, even before today's lecture. And again, had the uh, opportunity to also teach my regular students in Benz about two different years before. So that's great. All right. So if there's anything, as I said, it's specialty area, and so let us quite be a bit composed and then understand some of these few areas. And if you all have any ideas, we can share it as contribution in the chat or maybe come in and then talk about it. Right. So what really is burns? You said that what is a soft tissue injury, right? Damage to the skin, to the soft tissue. It's caused by what? Um, Agents that
Yeah, where
can
there no man can be more.
can
Yeah, no man can be. Yeah,
it affects the skin, and again, deeper tissues are also affected. It can go as deep into the bones, the muscles, and into the bones, right? And so, based on where the structure that are affected, we have the classification for that. We have types of burns, or we have causes or types, yes, of burns, the etiology. So we have the thermal burns, which I'm sure most of us, especially the women, we've all have had a few of that instances before. So thermal, the heat, the hot liquids, the steam, the oil, soup, water, flames, there are thermal burns. We have the chemical burns, acidic, alkalinic, many other organic compounds also. We have that as chemical burns. We have the electrical, low or high voltage burns, lightning injuries. They are all also electrical burns. And as part of our lessons, after we've done the whole general aspect of burns, we'll talk more of the electrical burns and then talk into the inhalation injury. Right. And then we have the radiation, the sunburns, the radiotherapy burns, they're also part of that. And we have the friction burns, heat, we have that heat plus a bit of abrasions, that is also friction burns. And then we have the cold injury, ice formation, tissue freezing, frostbite, vasospasm. This I'm sure um I don't know, I haven't nursed cold injury burns. I don't know, maybe from the developed countries, maybe they would really experience that. Right. So we have risk factors of burns. We have the extremes of age, right? The age, the children, the elderly, they are really affected. I'm conducting a study. I really need the high sample size for my quantitative I'm down with my qualitative, and then the quantitative, whenever I go to the wards, it's more of the kids, the kids, the kids. Even though I get the adults, I'm more into the adults, but they're not so much as compared to the children. So the kids are more affected. And then, of course, the elderly are also affected. The elderly are affected, yes, they are more of the weakness and the degeneration of cells and all that. So in a lot of comorbidities as well. And so even if they have burns, the healing becomes a bit of a problem or a bit of a challenge. Occupational exposure, occupational hazards are also there. Unsafe cooking and heating practices, and mostly also these are part of the reasons why a lot of our patients have burns, right? And then again, poor housing condition, that also is one of the major cause of burns. Then again, even the weather. Sometimes also when we're in the cold season, some of us want to light fire and then sit by it, like put diesel in a pot or something. All these things also causes burns. So these are some of the risk factors we may meet. Then prognosis. Prognosis. Mostly, the very major predictor of mortality is age, age, and then the total body surface area. The total body surface area. These are the basic, the main cause of mortality, right? The age of the patients with the kids or the streams of age, we talked about that. And then the TBSA, the total body surface area bend. And also, if patients have inhalation injury, they are also having a bit of bad prognosis, right? And so patients also who have other chronic conditions and then other comorbidities also, like the diabetics, the asthmatics, sickle cell disease, hypertension, epilepsy, peptic ulcer diseases, all these, you see, bears the fact that it affects all the system. All the system is affected. Yes, so if there are any comorbidities found anywhere, it is part of the major prognosis or predictor of mortality. So when you talk about the age, the streams of age, kids below the age of 5 years. And so if you read more of the research, you find a lot of papers within the kids that are below the age of 5. And then the older adults above 60 years, they also have the high mortality. So you know that we, the children, the immune system and then the metabolic system is quite immature, right? And so they will have that issue. And so the older ones as well, a bit of a physiological reserve, right? They have slower healing. I think I've said that earlier on. And then the TBS, the total body surface area burn, the percentage of body surface area that's affected by the burns, it is also one of the stronger predictor of or the outcome of burns. Burns
Meba,
above
meba.
40% TBSA is associated with. You see, yes, we are all working. We are all mothers. You see, I'll keep on saying it until we get a bit of behavior during lectures. And at the end of the day, when we sit to write exam, we want to more practice. At the end of the day, when we sit to write exam, we want to go out and then copy and then come and put it on our sheet and then recopy onto our sheet. And when we catch us, we call us to come back to campus and we pretend as if we didn't even we didn't even take part in more practice. Ideally, when it's lecture time, sit somewhere and then do a bit of writing, putting down some points. But then we will always be telling ourselves that because we are Methuselahs, we are always doing something. And then if you are doing something also, you don't comport yourself. And you also want to disturb some of us who want to pay attention and listen to lectures. From now onwards, please, I think who is the one I've been coming? Edward. Whoever talks, please write the person's name and index number and send it to me. If you don't do that, it means you are going to trail in surgical nursing too. If I don't get, because every day I'll know how many of us do that. So if you don't send me the list at the end of every lecture, I will trail you. I'm telling you, you are going to trail. Yes. Degrees awarded, right? You're going to trail. All right. Edward, I'm talking to you. And if you are also part, add your name because you will trail. Thank you. Anyway, so we're talking about the TBSA. So mostly above the 40% TBSA, it is really associated with high risk of death, basically due to fluid loss, infection, and even organ failure. I've said that all the systems are involved, all the systems, one or the other shuts or slows down. And so they're all involved. The larger the TBSA, the more severe that's systemic response. So the shock, immune suppression, even metabolic stress. I even said that one of the comorbidity PUD, they have what we call Kellen's ulcer, they have stress ulcer. So all these things are involved. So it becomes a problem in terms of their healing when the TBSA is higher from 40% onwards. And then again, with inhalation injury, you see, burns involve smoke, toxic substances, fumes, gases, right? And so that damage the airway and then the lungs. And so that also worsens prognosis, right? And so it causes that airway obstruction. There's carbon monoxide poisoning. Eh, They even have acute respiratory syndrome. I'm sure we have it in our slide. When we get there, we talk about it more. And then I think we've talked about the comorbidities where like example, the DM also would impair wound healing, it will increase infection, even complicate the rate at which glucose is even controlled, right? When you talk about asthma, we said that there's a risk of what respiratory distress, and so there'll be respiratory complications. Patients are even epilepsy. You see, seizures during recovery can also cause what secondary injuries. Even these seizures can one or the other even be the cause of the burns. And so afterwards, also that can also complicate injury and its management. And then with sickle cell and all that, we know that there's a bit of reduced oxygen delivery to the tissues. And burns itself also causes delayed oxygen delivery to the tissues. There's impaired tissue perfusion. Right, so I know we know the skin, the epidermis, dermis, subcutaneous tissue. Beneath it, we have the muscles and the bones, right? So we have the the classification by death of the skin. So in one or the other, that depends on the temperature, the time in which patient had that contact with whatever material, whatever flames, the contact time, even the skin thickness and the source can also cause that. It will depend on the death that patient would have. We have also the traditional classification. And so we'll blend that within our lecture here. So you have the according to the traditional classification and then the contemporary classification. So if it's traditional, it's the first degree, the second degree, the third degree, the fourth degree. And we have the contemporary classification where we'll say the superficial, partial thickness, the deep partial, and then the full thickness, right? So superficial thickness or the first degree, it is limited only to the epidermis, and so that is mostly what some of us have all experienced before, or better so nursed before, except maybe we are all those who have had that kind of specialty experience nursing these patients. Okay, so epidermis only, that is limited. That's the first degree, the superficial, right? It is very painful, and I'm sure we know why it's painful. If you don't know, whoever knows, please, you can put that in the chat box. Why do you think the epidermis is very painful, right? And that is reddish. We have erythema. We have patients, of course, I've talked about the pain. There'll be erythema, that redness. And then when just like we talked about the stage one pressure ulcer, when we apply pressure, there's a bit of blanchness, like there's that white in there. And then also with the first degree, there is no blister formation. there's no blister formation in the first degree. No blister formation, right? And then with that also, symptoms subside within between 2 to 3 days, and then healing takes place without scarring. Healing takes place without scarring. Then we have the second degree. The second degree, the partial thickness burns or the superficial burns, that is quite limited to the papillary dermis. But then it spares the skin appendages, right? For this one, there is blister formation. So that differentiate between the first degree and then the second degree. Blister will be formed. It is moist and very shiny. But then for that also, blisters mostly delay between 12 to 24 hours after the burns, and then we may see it may delay. The word is may, it may delay, it may delay, and then also between like 3 weeks, there's healing. Between 3 weeks, there's healing. We wouldn't necessarily see any hypertrophic scars. Okay. Yes, so because it contains sensory nerves, right? And the sensory nerve endings. So in the first degree burn, only the epidermis. So nerve endings are still alive. The burn stimulates sensory. This one, don't you think you went to take it from ChatGPT? All right. So the presence of nerve endings or the skin, right? So that is more of what the second degree burns. There's decreased sensation, there's poor capillary flow, yes, but then there may or may not be scarring, right? After healing, may or may not be scarring after healing. Patients may need skin grafting. Then we have the full thickness burn. Full thickness burn. The third degree, the full thickness burn. So the entire dermis will be destroyed. Entire dermis will be destroyed. Blisters will be absent because it will cause more harm. Blisters will be damaged, the skin will be damaged, and so the blisters will be absent. There will be leathery, bit of inconsistency, bit of hardening, and then it even varies. Even the color varies with where the injury has occurred, and then also because of that mechanism of burn injury. If there's no intervention, there'll be a bit of demarcation and then separation over days and weeks. But of course, these patients will stay at home, and then after they see that kind of changes, they will now want to rush it to the hospital. It will also lead to delayed wound healing, and then these ones also, they would have risk of what infection. They would definitely require surgical management. So of course, if the dermis is affected, the epidermis is also part, and then the subcutaneous tissue, the epidermis, the dermis, the subcutaneous tissue, right? So surgery may be required. When we talk about the fourth injury, the fourth degree, with the fourth degree, you see childness, like a cold, right? And so we see that we will see it extends to the deeper tissues, the muscles, the bones, the joints, right? For here, this is a bit of the distinct between the fourth degree and all other degrees. There wouldn't be that kind of sensation because I'm sure that once you have to know why patient wouldn't feel pain here, they wouldn't even feel sensations. So why do you think so? Why do you think so when you talk about the fourth degree? All right. Is there any question? Can we move on? Before we come to even the estimation of TBSA and all that, when we experience, should I say we experience, but we see patients in beds, or maybe even we are within a smaller hospital, health center, chip compound, smaller facility, and all that. What do you think will be the criteria to transfer a patient to a burn center? You see, we don't have those centers around. In Ashanti region here, it is only Komanochi Teaching Hospital, though other hospitals also nurse burns, but mostly they just stabilize the patients and transfer. So what will be the criteria for transferring patient to a burn center? To a burn center. So with the 4D, that made nerve end is very good. That made, yes, painless because of nerve distraction. That's great. That's great. So what would be the criteria for transfer of burns patients or patients who have had burns to the burn center? Okay. So yes, patients who have third-degree burns. Third-degree burns, that's great. Yes. Third-degree burns. Spots. What else? What else? Criteria to transfer patient to a burn center. Okay, so let's move on. So patients, yes, somebody Matilda rightly said were third-degree burns. Yes. Yes, electrical or chemical burns. That's great. That's great. Electrical or chemical burns, full thickness burns. Yes. So of course, the last degree, then you don't have to even hold on. I see full thickness can be rated within third degree also. Yes, these ratings, third-degree burn can also be classified as a full thickness, even though it is more given to the fourth degree, right? Can be extensive burns that will require skin graft. Yes, total body burns. Patients with what? Inhalation injury. That's great. And then patients who have comorbidities. Yes, yes. So mostly, if a patient even have superficial burns, even though it's superficial, but then it is TBSA rates it 10% upwards. They are supposed to be sent to the burn center. As we rightly said, third degree, yes. Burns that involve the face, the hands, the feet, the genitalia, perineum, and other major joints, they are supposed to also be sent to the burn center. You rightly said the chemical burns, electrical burns, yes, inhalation injury. So if we suspect, and we are going to learn about some of the things, the signs and symptoms we will know, or observation, we will see that this patient is having what inhalation injury, and so they are supposed to quickly rush the patient to the burn center. And yes, the pediatrics, right? Yes, the pediatrics are supposed to also send to the burn center. Severe bleeding and dehydrated patient, and then with organ failure. So all these things, we are supposed to even send them before we even notice these other complications. That's great. That's great. That's great. So you still talked about what if there are any other trauma. So we see that, yes, somebody talked about full thickness, so 4-degree burns, right? So any other trauma that will cause, or we would know that when you try patient is at risk of what? Death. Any pre-existing comorbidities, I think you talked about that. You see, also, if we are truthful to ourselves, and we know that this hospital does not have the qualified personnel and then the qualified equipments to care for burn patients. You see, yeah, they are specialists or specialty area. And so it's not the usual small pieces of gauze and the small what I don't know infusions or whatever solutions we use to dress the patient these burns, right? And so if we see that we don't have the qualified resources, equipment, personnel, maybe you haven't even nursed it before. When patient comes, when you stabilize the patient quickly, let's refer the patient, right? And so again, patients who require what? Yes, that one we can do that best. Any special emotional support, we can do that. But if you think that it's patients maybe is depressed, especially patient having burns on the face, the perineum, there's a bit of depression and all that, we should let patient go to a specialist center. And then also patient who need any rehabilitative intervention, we should know that yes, that means that either they are within the TBSA that are higher, and so definitely after everything, even with the small, even the first degree, patient may need rehabilitation depending on the contact and the source, the temperature, and all that we've talked about, right? Okay, so TBSA estimation. I'm sure we've all heard of the rule of 9, right? You've all heard of the rule of 9. So mostly rule of 9 is accurate in adults. It is a very quick estimation or a way to estimate the percentage of burns, the rule of 9. And so we are going to talk about, or should I even ask you, because we are all doing revisions, right? Yeah. So what is the percentage? When you talk about the rule of 9, if it's the whole arm, what will be the percentage? If it's the whole head, what will be the percentage? And neck, what will be the percentage? Is the lower limb, what is the percentage? One lower limb. If it's the trunk, what is the percentage? Please, can we have it? We are all doing revision. Rule of 9. Head and neck, what is the percentage? Okay. Okay, so maybe when we state it, we can make us know if it's 9, is it head and neck? If it's the lower upper limb, one upper limb, what is it? One upper limb, what is it? One lower limb, what is it? Right? And then the trunk, what is it? Let us all learn that now. And it's very, very important, please. After here, try your best and search for pictures on that. The rule of 9, search pictures on it, please. Then put it on your various platforms. You need it. So the whole head is 9, right? So it means that the anterior portion will be what? If the whole head is 9, what is the anterior portion of the head and neck? You should be able to know that. If the whole, okay, so 4.5, very good. 4.5 for that. Good. Then if we are, let's come down. Now we are done with head and neck. Let's come down. Where should we go? Is it the first upper limb? So the upper limb, let me check the chat box. Who of us have written it and stated the item? Oh, okay. So we have one of us here who have stated all of it. So head and neck 9. So 4.5 for anterior and posterior. Great. Then each upper limb 9, right? So total anterior 4.5, very good. Posterior 4.5. And then we have our trunk. So we have the torso, as he said over here. So we have the 9, right? Anterior and then posterior. So 18. And then we have the lower limb. We have the lower limb here, which is 9 for the anterior. And then 9 for the posterior. So the whole lower limb will be what? 18, right? So one leg is 18. Very good. Please get it right. And the other leg, the whole is 18. So if it's just the anterior, it's 9, right? And then the perineum, we have it as what? 1. That's great. That's great. Please, after here, go and revise. Right. So we have another method. Another method which is basically used in the teaching hospitals, the Land and Browder. It can be used for both the children and then the adults, but it is very accurate that is, it is more accurate for all calculations. Yes, and probably very good also for the, no, I'm not using the word probably, please excuse me, sorry for that. Very accurate for both adults and then children, and more accurate in children. More accurate in children. Please find out why Land and Browder is more accurate in children. Find out why Land and Browder is more accurate in children. And so with the Land and Browder, we have measurement for the, I'll try and that one up. I've uploaded all other slides for up to today's slides on the V class. So, but I didn't add this one. I didn't think it was really necessary, but it is. So I'll upload one that has been even done. ID one has been done even from the hospital. In there, I uploaded the Land and Browder where we have the parameters. We have the area where A, B, C has been designated for the head, one thigh, and then one leg. And then we have it in ages, age 0, age 1, 5, age 10, age 15. And then we have the adults, where we have some percentages, some what numbers designated for each age based on whether the head, whether the thigh, whether the leg. And then we have a constant figure also for the each body part, constant figure for that. And so for those constant figures, let's give me a moment. Let's see if I can share that slide, because I don't think I can just talk in abstraction for you with this. I'm sure most of us haven't heard of Land and Browder. Give me a moment. All right. So if you can see it over here on the screen, you realize that, let's see what you have over here before I continue. Okay, so somebody has rightly brought it over here. Great, great. All right, so that's it. If you've had a picture here, then I can go back to my slides. So yes, so Kingsley has made us know why that you can read it by yourself. It's quite lengthy. We have the rule of 9 here, but you see, when these pictures are just put in there, you just see it and that's all. Please, after class, if you get time and you're not only nursing your husbands and then your kids, find time and sit down and then see if you can revise these things, it would help you in so many ways. So yes, so as we've seen here, I wanted us to see a real chart, and then you see that there's even the teaching hospital's name in there, so it means that it's in use, right? Yes, so where you find the body, whatever figures you find in there is constant. So where you find 113, 2, 1.5, they are all constant. 1, 3, 4, they are all constant, right? But where you find the B, C, A, it means that they are subject to change based on the years of the individual. Is that okay? Based on the years of the individual. And so you realize that on the other side of the chart, the whatever, right or left, depending on how you are seeing it. On the chart, we have a graph there where we have the superficial bands and then the deep bands as well. And so it has been also what shaded accordingly. And so we use that to now calculate for the total body surface area of burns for the patient. I hope that is quite clear. If it's not clear, please, you can come in and then let us know why you are not so clear with that. All right. Are we clear? Can we move on? All right. Then we have the Palmer method. What do you think is the Palmer method? That's the easiest. What do you think is the Palmer method? Can anyone come in to tell us about the Palmer method? Palmer method.
Sister,
Yes, my dear.
sister,
Yes, my dear. Palmer.
with the Palmer method, you
Mhm.
also call it the Palmer's rule,
Mhm.
where you use individual's hand to
Mhm.
measure the area which the
Mhm.
burn occurred.
Very good.
So that is what
Very good. Very good. Thank you. Thank you, Senior Samuel. So one of my seniors here as a best specialist, I know you would come in no matter what. That's great. I'm grateful. Thank you very much, my dear. All right. So the Palmer method that he rightly said, we use the palm, right? To measure, and then mostly for small bends, right? Mostly for small bends, and then per palm is what? A percentage, right? Yes, that's great. That's great. All right. So yes, so Rita is also saying used for small, irregular, or scattered bends. That's great. That's great. Thank you very much, Rita. Thank you, my dear. So yes, so if it occurs, what happens? If the bends occurs, what happens? What happens? You see, ideally we have the local effects and then we have the systemic ones as well, right? And it's mostly the local effect that will lead to the systemic. Is that okay? So definitely there will be inflammation that happens after burns. There will be inflammation, and then these inflammatory mediators will be exposed. They would all want to rush there, the histamines, the serotonins, the prostaglandins. You see, burns and stuff that all the chemical mediators want to come in there, come in play, right? They all come in there. Now, that will also cause what? Increased capillary permeability. And so there'll be increased capillary leak. right? So that leakage of fluid from these vessels into these interstitial tissues will now cause what? Massive fluid loss, which will lead to what? Edema, right? It will lead to edema. This increase in fluid within these intravascular spaces now, electrolytes will be lost, there'll be protein seepage. All these things will now cause of low cardiac output, there'll be suppression of immune systems, and eventually there may be fluid loss. Of course, there is fluid loss leading to what? Hypovolemic shock. Their fluid loss is very, very rapid at the first instance. It is very rapid, very, very rapid at the first instance. But then after 18 to 24 hours, there's a bit of reduction, especially when the integrity of the vessels are restored. That is when there's the reduction. And so those in the burn centers who are really gone for this training will tell you, or those who have really nursed, you see, the more you nurse, even if you haven't gone on a training, as a very, very proper nurse, the more you nurse the patient, you would want to read more about it and then know more and know how to care for the next patient, whoever comes in, right? Yes, we call something reflective journal. I'm sure in 400 you learn that. So that if you do something, you're not doing it right, the next time you want to improve upon it. And so you reflect upon that, you journal upon that, and then the next patient you want to do better. So you read. And so you realize that no, this and then maybe this one, fluid loss, I didn't really resuscitate patient very well. The next one that comes, I would want to do that. And so you read more about it. Yes, they have rapid fluid loss, but then it sustains when the integrity of these vessels are quite restored. And so the first instance, we want to give what? Fluid resuscitation at the first instance, right? To revive or to, not the word revive, but stabilize the patient. Is that okay? Right. So we have the systemic effect. We have the systemic effect. Cardiovascular. Cardiovascular. What will happen to the patient? What will happen to the patient? We said that there will be low cardiac output, there will be fluid loss, so they will lead to shock and all that. What will happen to this? So when there's plasma leak out of the burn area, there's of course major fluid loss, and so it causes low blood volume. That will lead to this hypovolemia, and then it will lead to that burn shock, right? That burn shock. You see, when burn patients come in that first instance and you take their blood sample, you want to go and check for their let me even say HB, you see it as very high. You think that, oh, okay, they're okay, right? They have what you call hemoconcentration. Hemoconcentration. There's a leakage of red blood cells due to this diapedesis. It is inflammation, if you revise it. So there'll be leakage of these red blood cells. And so the blood becomes thicker. Are we getting it? And so there's hemoconcentration. And so if the blood becomes thicker, now it is also leading to what? Clot formation. Is that okay? So that thick blood, it will slow the flow of blood, and then it will cause what? Thrombosis. Right? So this hemoconcentration, keep that in mind. When we are talking of electrical burns, we would talk about something else, add it upon it, and then we come to a complication. All right. So we've said that earlier when they come, it is about what? Fluid resuscitation, right? Because there's a very maximum fluid shifts. And so that's the basic thing we have to do when we receive these patients. Their swelling quite reduced after 24 to 48 hours. And then they now have a balance of fluid by the 5th day onwards. Now their urine output quite increases. But before then, because they have low cardiac output, they also have low urine output as well. Is that okay? So we are now getting into what? The renal system. There's oliguria, or better still, anuria at the first instance. We talk about what? Increased hemoconcentration. Now myoglobin has come here. I'll just leave it at that. Or better see if I can talk. I wanted to talk about it during the electrical burns area, where we get to electrical burns. But then if it's found over here, so we are talking about the whole pathophysiology of burns. So maybe you can talk about it. When you see myoglobin, then it means that the muscles has also been what? Involved. If the muscles are involved, then it means we've gotten to what? The full thickness burns. Now, if you get to full thickness burns and then the muscles have been destroyed, there will be what? Increased production of this myoglobin. If myoglobin are increased and then it's attached itself to the high concentration of this hemoglobin, it causes what we call acute tubular necrosis, or better so, acute renal injury. Because it runs through the blood and now it gets into the kidneys and it causes harm. Right? And so there wouldn't be enough tissue perfusion within the kidneys. They'll be acute tubular necrosis because of what? The combination of myoglobin and then hemoglobin. So there's acute renal failure. Is that okay? All right. And then respiratory system. Respiration. Respiratory system, what happens? There's airway edema. We've talked about edema. And so there's airway edema over here as well. Patients generally, especially with inhalation injury, they have narrowing of the airway. And so as part of course, as part of the management, as part of the fluid resuscitation, we still would want to do our ABCs, right? It's part. We can't ignore that. It is part. But whilst we are doing ABCs, we also have to do fluid resuscitation. And then they also would get what? Acute respiratory distress or acute lung injury as well. And then leading to what? Respiratory failure, pneumonia as well, chest infections can all come in here. That's okay. Now we have the GIT. What will happen to the patient's GIT system? Paralytic ileus. I'm sure we've met paralytic ileus before, so we know what will happen. Paralytic ileus, right? Why do you think the paralytic ileus? Of course, there's reduced bowel movement or motility. There's Kellen's ulcer, stress ulcer. So the stomach, the duodenum, or wherever, there can be what? Risk of bleeding and perforation, right? And then, of course, infection also come setting, sepsis risk setting over here as well. Now we have what? The hematology. We shouldn't even forget that for the GIT, patient may even have constipation. There is dehydration. They are also immobile at that point. And so they may have what? Constipation, right? Now the hematology, of course, we were talking about the red blood cells. There's that rapid destruction of the RBCs over here. They are lost within the first instance, the first 12 hours. They have issues with that. And that's why I said that they'll be what? That's hemoconcentration, right? And so they become fragile, they break away, and then they lose their lifespan. They have shorter lifespan around that area. Yeah, so the patient will be anemic, and then there is sort of low immune suppression. And then the CNS. Of course, with these patients as well, they also would have immune suppression, so they would have WBC counts are often low. When there is infection, when there is sepsis, that is when it may be raised. So get the difference as well. When there's infection, that's where it will be raised. They would have restlessness and confusion due to what? Hypoxia or dehydration. We should know that when there is burns, there is decreased blood flow to all other organs, and so including the brain, there'll be reduced blood flow and oxygen to that site as well. And so there'll be that neurological disturbances, right? Okay. Are we okay? Any questions? Any questions? Any questions? Can I move on? Okay. Inhalation injury. Inhalation injury. So when we talk about inhalation injury, Gregory. Yes, my dear.
Just as you asked us to remind you, I was just sensitizing you that we are almost an hour in, 4 minutes to an hour.
Okay. Let me just at least we've explained a little bit, right? So we can now rush a bit. Let's just finish with the inhalation injury. The rest we've all managed them before, so we've managed bends, so it won't be so much. All right, thank you very much. Draw my attention when it's about 15 minutes as well, right? All right, thank you. So when we talk about inhalation injury, we have some mechanisms for that inhalation injury. So you have the carbon monoxide inhalation, you have the direct thermal airway thermal injury, and then we have inhalation of toxic smoke. If we have patients who have inhalation injury, mortality is basically 60% and above when there is inhalation injury. You see, when there is inhalation injury, there is carbon monoxide inhalation. Why would there be inhalation? Mostly when there is burn in an enclosed area. These are when patients will experience inhalation injury. We would now be breathing odorless, tasteless carbon monoxide. And so they wouldn't even know that it is causing harm. It is very toxic. Inhalation injury, carbon monoxide inhalation has about 250 times affinity. Don't forget that. 250 times affinity for HB as oxygen. And so it displaces the oxygen from HB, from the hemoglobin, right? And so it impairs tissue oxygenation. Imagine that the oxygen has been detached from the HB, and now it's carbon monoxide that has been attached to it, and it has 250 times affinity to that. So it means that it is very toxic in the system. And when we talk about direct thermal injury, this superheated air around where there's that burns or where there's that injury causes that edema in the face, the upper airway, the respiratory system, and it causes difficulty in breathing. That also happens within the first 18 hours, 12 to 18 hours to 24 hours, and then it resolves gradually. Of course, over days when intervention is in place, right? And then toxic smoke inhalation. And so that one's when they inhale that product of combustion, the ketones, other organic acids, the combustion of or other synthetic materials. All those things will also cause what pulmonary edema and then acute respiratory syndrome. Now, the signs that you know that this is an inhalation injury, and I've also said that what it happens within mostly at an enclosed area, right? Enclosed area. So, class, room, bedroom, factories, offices, and all that, right? Patients would have what? Hoarseness or weak voice. There will be increasing stridor. We would see patient having soot in the mouth and then the nose as well. The patients will have they'll be restless, they'll have difficulty in breathing, they would spit black sputum. They call it what? Carbonaceous sputum. When they manage to spit, it is carbonaceous, and I'm sure you know the reason why. They also have soothed mouth, soot in the mouth and then the nose. They have singed nasal hair. Their facial hair, their faces, and then the nasal hair will be singed. And then also they have swollen upper airway. So if you see all these things quickly, and it is an emergency, we don't have to play with it. with inhalation injury. It's very, very urgent. How would you want to manage inhalation injury? Okay, I think this one. Okay, that's great. How would you want to manage inhalation injury? Let's talk about that quickly. When we see patient like that, we have to call out for an anesthetic review.
Yes, please.
So we should know that, you see, if you don't have a hospital where you have this anesthetic always in place, then what will happen? We have to maintain their airway. We have to get nasal and this endotracheal tube. We need it. Inhalation injury, we need it. We want to maintain ventilation, right? Yes. Then again, because of the carbon monoxide poison, we need 100% oxygen, and then we give them non-rebreather, right? The oxygen is given in the non-rebreather mask. You shouldn't forget that. They need high oxygen, because we've said that the oxygen has been displaced with carbon monoxide. Don't forget that, right? And so that is basically some of the things we are supposed to do, including all our airway ABCs. Are we okay? In terms of management, we have something we call, I think some they say here, is it what? Emergency, acute, and rehabilitation. For general burn management, here, emergency, acute, and then rehabilitation phase. That is for general management of burn patients. So what is the emergency phase? So the emergency phase is where we want to resuscitate patients, where we want to give our IV fluids, our NURS lactate, right? And then our acute phase, we want to prevent infection, you want to maintain nutrition, you want to maintain wound healing. And then our rehabilitation phase, where we want to prevent contraction, we want to psychologically want to talk to patient for patient to get back to his normal states of health before burns, or psychological states, and then also reduce all complications, right? So we want to, the principles of manual revive, restore, repair, and then we want to rehabilitate. First aid management. Of course, we want to stop the burning process. And so as part of, maybe before you bring patient to the hospital, stop burning process, cool with running water, cover with clean cloth, and then we want to transfer patient to the hospital. So we have ATLS protocols. I'm sure of late, a lot of hospitals are doing workshops on that. So airway, breathing, circulation, disability, and then exposure. Mostly, if the exposure is bad, then mostly when you are doing it away from the hospital, right? We want to ensure that patient is not even still under danger, right? Yes. Some of the Ds are even saying danger instead of disability. So maybe you can just take one. All right, so we want to revive patients and ensure that patient is okay, and then airway, the breathing, the circulation are all intact, and then prevent any complications, and then this exposure. Fluid resuscitation. The main fluid we use to give these patients is what? NURS lactate. NURS lactate. Don't forget it. Now, the formula that is used to nurse to calculate this infusion is what? The Parkland formula. The Parkland formula. Find out why we don't use sodium chloride, the normal saline. Find out why when we are resuscitating, we say we have to use NURS lactate, but not sodium chloride. Please find it. So now the Parkland formula, we use what? It's what? 4 mils of fluid plus body weight plus percentage of TBSA. So it means that before we can even nurse the patient, we should be able to know the percentage of TBSA. Of course, there's bends, and we've learned that, we know that we have to calculate for patients what? The percentage of bends. So without it, how can we nurse the patient? Without it, how can we nurse the patient? All right. So how to calculate for the fluid using the Parkland formula: 4 mil times the body weight. So if maybe 60 kg or whatever, times, let's say 37% of the total body surface area. And we use that to calculate for the for the Parkland for the fluid to give to the patient. But then, after we've had the calculation, then what do we do? After we've had the calculation, then what do we do? The first 8 hours, we give them 50% of that amount you are supposed to give in 24 hours. 50%. So let's say we've calculated, we've had, let's say, 1,000 mils. Let me just put it that way. Yeah, that's quite simple for us to discuss that. So 1,000 mil means that the first 8 hours, we are giving 500 mils in the first 8 hours. And then the next 16 hours, we spread the remaining 500 mils. That is our way of managing the patient. We've talked about them retaining what we having low cardiac cardiac output and low urine output and all that, and so we want to maintain help them with fluid resuscitation, right? And so the first 8 hours is the 50%, and the next 50% is what? The next 16 hours. That is for ringer's lactate. We want to target their urine output. And with their urine output, we have to titrate that fluid at, if it's adult, always per hour, you should get at least 30 mils of fluid. 30 mils of fluid per hour for adults. If it's low, then there's a problem. And if it's pediatrics, then 1 mil per kilogram body weight per hour for them when we are monitoring their urine output. Okay, I'm sure we can go and read more about that. Ben's is quite extensive. So if we still cannot finish and then do the other class, don't worry, we'll make it to next week. It's quite extensive. And so, right, so as part of the management, so we know that the first few instances, we are doing fluid resuscitation. We are giving ringer's lactate. I said you should go and find. I couldn't read what is in the chat box because I was quite now wanting to rush, so I couldn't. So please find out all those things. And then we know the 50-50 rule, where we have the first 8 hours, the first 16 hours, right? Now, let's say we have, in a way, stabilize the patient, right? And then also find out, for them, they have a bit of temperature issue. I don't know, we didn't talk about that. Temperature issues. So find out why, if there is time after here, maybe I'll let one of us come in and then explain that to us. Why are they cold in a way, and then just within some few minutes, they now are complaining of heat, right? To find out. Right. So after now we've stabilized the patient, we want to now do wound care, so cleanse wound using our typical antibiotics. The main one they used was sulfadizine, right? I'm sure they have others. They have a lot of other ones, but I think this is the standard one that is used. And so they're also prone towards infection. We've said that their immunity is very low and all that. And so please, the addressing, it is really done under proper asepsis. Then we change the addressing if soaked. Medications, we don't forget their pain medication, and then opioid is preferred. If there are issues with the medication, please, after here, please, if there's any contribution, you can add on for us, right? Then also we give them prophylactic antibiotics. Prophylactic antibiotics is given after they've been stabilized. That is what we give them after they've been stabilized. So so no prophylactic antibiotics before or 24 hours unless contaminated. So mostly after stabilization, we give it to them. And then also we want to ensure that there wouldn't be a stress ulcer, and so we give them prophylaxis of that. Rehabilitation, early nutrition, they really would need what? Protein, high protein diet, right? High protein diet. They need that. So when you go to them, what they'll say, they should take 6 eggs a day. 6 eggs a day. Some of us cannot take 6 eggs, so, but if there is Ben, whether you like it or not, they're supposed to take 6 eggs a day, right? So high protein diet, they need it. Then high caloric diet. These are just a few. So find out more of what they need in terms of their nutrition. Please find out. Then physiotherapy, splinting, infection prevention, warm environment, surgical management. We can do debridement. We can do fasciotomy if it is what, especially with the limbs, right? Yes, especially with the limbs and if the muscles are involved. And if you suspect what compartment syndrome, you have to do fasciotomy. Skin grafting, yes, skin grafting mostly they do for them, depending on the extent of the wound. Amputation and any reconstruction, that is done. Oh, no worries. I'm sure I don't know if I can still do the other class. Right, so electrical bends. Electrical bends. Whenever we suspect electrical bends, we have to always find the contact point and then even the exit point, right? Because depending on the extent of the electrical injury or the equipment, or how do I even put it, whatever has caused that electrical bends to occur to the individual, right? For electrical bends also, you have to always know that when the patients come, you monitor their ECG and then their EKG as well. We have to know that, you see, the heart also have its electrical impulse that helps in diastole and systole. And so imagine I already have my pacemaker or whatever helps me in performing my function, and there's another electrical activity, what will happen? So mostly they are at risk of dysrhythmias. These patients are really at risk of dysrhythmias, and so we have to monitor their EKG, their ECGs. We do cardiac monitoring a lot for them. We want to also do renal function tests as well, because mostly for electrical bends, they are at risk of full thickness bends, and so their muscles are involved. And that is why I said that there will be what myoglobin produced, and then in combination with the what hemoconcentration, patients will be at risk also of what acute renal or tubular necrosis. Is that okay? When you want to suspect myoglobinuria, we will see that patients will exhibit what tea-colored urine. Tea-colored urine. You want to maintain urine output at between 75 and 100 ml per hour to minimize the myoglobin. We want to minimize the precipitation of what myoglobin. Is that okay? We have to know that. Also, we give them what sodium bicarbonate or mannitol. They will need it. They will need sodium carbonate mannitol. And then also for them as well, we still want to monitor for risk of what compartment syndrome if the extremities are involved. Okay. So these are the complications. Any questions? How many minutes now? Any questions? Do you have any questions? Can we move on? Sorry, I couldn't go through. Is it for all the degree of it? Yes. Rehabilitation, yes. Who coming to help us with the rehabilitation question here? Is it for all degree of bends? Is superficial bends also part?
No, please.
Superficial is not part, eh? What if I have superficial bends and then for me, I'm a fair colored person. So even though there wouldn't be any scar, I wouldn't know. I'm not a health person. So I didn't even know that what is over there will heal within or would vanish within maybe 2 days or a day. Or what do you think? What do you think? Yes, but ideally for rehabilitation, superficial, yes, superficial burns, it's quite spared, right? It's spared. It's spared. It is mostly for which degree of burns? Yes, Sister Magdalene. Which degree of burns? Rehabilitation.
Sister, please, from second upwards, second degree base upwards.
Okay, from second degree downwards. So that's great. So another one of the
Downwards, sorry.
thank you. Another one of the burn specialists nurses I have encountered during my research has also talked today. Thank you, my dear. Very grateful. Okay. Let me we have 30 minutes more, I'm sure. We even have 45 minutes, right? Yes. So we can still finish up with wound coverage. I'm sure that one, skin grafting, all of us, we've known skin
Sister,
grafting,
please,
right?
the electrical base, The complications of the electrical base mostly comes, the amputation comes in.
Okay, that's great. So for complications of electrical burns, also amputation comes in, right? That's great. That's
Amputation,
cool.
dearticulation, they are mostly associated with the electrical base.
Okay, thank you very much. So let's all find out why.
And also the damazine, silver nitrate, after 24 hours, we don't use it again.
Okay. So demazines, phosphidizine, after 24 hours, we don't use that as well. That's great. Thank you very much, my dear. So what do we use after 24 hours, please? What do we
Maybe
use after
Lesporin
20?
ointment or dress, Lesporin
Okay.
ointment or dress cream.
Lesporin ointment or dress cream. All right. Thank you. I'm trying to
If there is
project
a deep burns, I will use the dress ointment, not lotion, but cream.
Okay, so if there's a deep burns, we use what? Dress what?
Dress,
Okay, dress
dress
ointment.
ointment or dress
Okay.
cream.
Okay. Thank you.
If
Let me try
if
and
there is a
show.
superficial burn, we use Lesporin cream.
So we are noting it down,
But
right?
if there are, uh, please should I continue?
Oh, please continue, my dear. I'm still setting up. Yes.
Okay. In some cases, we also do a sclerotomy. Apart from the fasciotomy, we also do a sclerotomy.
Okay. So these are all part of the surgical management and
To remove
nursing
all the
management.
excess so that
So I'm sure that let's go and then read more about these ones. Even yes, we know that with that we have ESCA. We talked about ESCA as part of the symptoms of this what 3rd-degree burns and then the 4th-degree burns. Yes, so all these things are supposed to be done. Josephine, 2 minutes. I want
Yes,
to start
sis.
this lecture. Yes, my dear.
Um, please, with the Lesporin, I
Mm.
remember when they went for workshop, they
Mm-hmm.
made changes. So they told us that Lesporin
Mm-hmm.
should be used for the facial burns, and then while dress ointment is used for the body. So I
Did they
want to
give
know
did they
if
give reasons for that?
we sometimes use we don't use dress ointment on the face because it will be too harsh on the face. We normally use Lesporin ointment on the face.
Can we
yeah.
come?
But sometimes when the
Can
wound
we
is
have
clean,
hello? Can we have just a minute talk on all that, and let's have to summarize it so that I
oh,
can move
okay.
on. Mm-hmm.
And when the wound is clean, okay, it normally depends on the type of wound. You don't usually use any type of topical agent that you want. If you see that there is a clean wound, you have to use Lesporin. Deep burns, dress. Another clean wound, propolis or Miss B.
All right.
We don't use dress ointment on the face.
All right. Thank you very much, my dear. So
We
can I come in here? Yes, can I come in? Thank you, my dear.
yes,
So you see, in all this, we have different lotions, right? And as practicing nurses, we also know that um we have various lotions for various wounds and various management of these wounds. So from here, please let us all go and then read more about these lotions. There are lots of lotions. Even when you go to the Ben's word now, the Lesporins and then the dress we are talking about currently, some of them have different types, something else that is not on the norm but is used. So please let's all go and find out and then use that to help our patients, right? Can we now move on? So wound coverage. Wound coverage. We have wound graft, we have wound flaps, skin graft, and then skin flaps. What really are they? So skin grafting, we know that is a technique where the section of the epidermis and then the dermis is detached from its own blood supply and then transferred as some sort of a free tissue to a distant site. And mostly they call that distant site or the recipient bed or the graft bed. Is that okay? They call that the graft bed or the recipient bed. And so we said that's what there's a detachment of the epidermis and the dermis from its own blood supply to another part, right? All right. And so it depends on what? Dependent on the recipient side for revascularization. So during skin grafting, what do we do? Why would we even take another skin from another part to a different part? So the indications for skin grafting, we do that to repair defects that result from any we want to excise any skin tumors or anything. We want to do skin grafting. We want to cover any burns of the skin. Also, we want to do skin grafting. When we want to, there's a wound that is not closing, and that is not closing. Inside, there's not sufficient skin to cover up the part. Also, we want to do grafting. When a very primary closure of the skin also will cause a lot of complications. Also, we want to do skin grafting, right? And then also even the normal primary closure of the skin, also when it can cause an interference. Also, we would want to do skin grafting. We have the autograft, can also be even called homograft. When patient's own skin, so a tissue that has been obtained from the patient's own skin, autograft, and that is, I think, the common one we normally see, right? And then the allograft, tissue obtained from a donor of what? The same species. And then we have the xenograft from another species, right? And then we have types. I'm sure we've all heard of split thickness or partial skin grafting. And then we have the full thickness grafting. So the split thickness, we have the thin, the thick, or even we have the intermediate. And it can be cut at various thickness, right? And it's commonly used to cover large wounds or any defects which a full graft or even a skin flap won't be so practical. And then we have the full thickness. You might give me just a moment. We have the full thickness. That also consists of the epidermis and then the entire dermis, basically without the underlying fat or subcutaneous tissue. Wounds that are too large to be closed directly also want to do full thickness skin grafting. And then also better for cosmetics reasons, right? Ima, yes, can you come in?
Okay, thank you, Zita.
Yes, my dear.
Please, my concern is the allograft and the xenograft. Please, you said the allograft is done on the same species, and the xenograft done for different species. Does it mean that the same species, the relative, or like taking the blood group, or what? What do we consider as the same species?
Okay. So allograft, the donor from the same species. So let's say you and I, right? Or what do you think? I should even answer. Please, somebody should come in for us, so that I can move. Somebody should come in for us. So what can be the difference between the allograft and the xenograft? What really is the allograft? When you talk about same species, what really is it? And we talk about the tissue from another species. Please, what is it? Can we come in? Thank you very much, Ima. I'm sure it will be clarified. Okay. Thank you. All right.
Okay.
Okay, dear. So application. Ideally, how do we even select the donor site? We have the recipient site and we have the donor site. How do we even select the donor site? We have to check for what the vascularity of the site. Well vascularized recipient bed. That means that when we take it, then healing can take place quickly, right? And then also, if you want to achieve the closest color match, we want to take it from there upon assessment. Even in terms of the texture and even in terms of hair bearing quality, you see that skin appendages are all involved. And so we have to do all those assessments and check whether picking it from here to here wouldn't cause any complication. We wouldn't say that more is all harm than good, right? Yes. And mostly also after the donor sites have been taken away, then sometimes healing even of the donor site that should have been quickly healed now becomes a problem. And so we have to ensure that we obtain the thickest possible skin graft without jeopardizing the healing of the donor site as well. And then how we are able to even manage the resulting wound that comes from the donor site. Sometimes patients upon discharge, when you send them home, you come back and you didn't know even how they dress the wound, or where they send the wound to for dressing. They come in and even the donor site is rather infected. How to even dress the wound? They wouldn't use the necessary items, Vaseline gauze, so that there wouldn't be that kind of pressure on the wound. Before you realize, all granulation tissues have been destroyed and all that. So all these things, ability to even manage the wound will be a problem. It should be assessed, and then it should be a criteria for taking that. And then as better to the cosmetic effects. Has somebody answered Ima's question? Okay, so human to human, right? For the which one? Allografts, right? And then xenograft animals to human. Okay, so different species, human to another animal species. Very good. So I think that Ima can get the answers from there. All right, we can move on, right? All right, so what really is even tick? Is it phases of grad tick? What is the tick? What is the tick? Even before we talk about tick, let's even quickly talk about where the sites where we can even select the donor site, or the sites where we can select the site for donation for grafting. So when you talk about split thickness or the partial thickness, mostly we know the thigh, right? I'm sure all of us we've seen the thigh as a donor site before. So the thigh, the anterior abdominal wall, you see the reps who I'm sure you are also host. Take off Zoom user. Take him off, because even he doesn't have the right credentials to log. Take him off. Let's see if I can do that on my own. Remove. Magdalene, put off your video. And infinite hot, go off. Infinite off. Let me remove you. Anyway, if we don't finish with the lecture, all these things are apart. It means that I'm done with wound coverage. Next week will be something different. Right. So mostly I said the partial thickness or the split thickness, mostly the thigh. We've all seen that before, right? The abdominal wall here, especially the anterior abdominal wall, and then the buttocks can also be used as the donor side. For the full thickness skin grafting, mostly the pre or the post auricular part, the groin, the upper lid, that is also taken at a small portion as compared to the split thickness, right? And then also the supraclavicular area, we can use that for the for the areas you can select to do the grafting. We have types of skin grafting. We have the meshed, we have the sheet. Please go and find out more of that. The meshed, the sheet, the pinch. We even have the postage stamp, right? So find out more. Why meshed type of graft, why the sheet type, and the pinch, 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 and then the postage stamp. Kindly read more on those types. Okay. So take. I'm sure we've also heard that, oh, it has taken. Oh, the graft has taken. Or the graft has taken. So when you say take, the skin that has been taken from the donor side has been able to reattach and revascularize to the skin of the recipient's bed. To the skin of the recipient's bed. So that is what take. And so if it is taken, then it means that it is well attached to the sites, and so healing can take place very well, fastly, and we didn't have any complications, right? The graft process of revascularization. All right. So we have the imbibition, we have the inoculation, and we have revascularization. So imbibition is mostly the phase 1, where we have what? Diffusion of nutrients. It's within the first 24 to 48 hours. That is where the fibrin layer hold grafts in place at that site. There will be what? Proper absorption of these nutrients into the grafts. Mostly, of course, we know that out of what? Capillary actions, and that helps in what? Diffusing blood and the nutrients and oxygen to the site. When we do skin grafting and we realize that the graft appears pale, it is quite edematous, then we know that there's no proper water diffusion, right? Mostly at this point, we encourage that the graft is what? Immobilized, so that there'll be that close contact to the wound bed. Okay. Now we have inoculation. They call it the kiss. Yes, phase 2, the kiss. Capillary alignment. So that is when donor and the recipient's capillaries are well aligned, and then the nutrients now passed to the graft bed, right? And then we have, at this point, we should know that we should expect a pinkish, the graft should be pinkish, right? Because circulation has now what started at this point, right? So the graft should be pinkish, but still, they're still fragile, and so we have to still encourage not enough activity of the limb or wherever, so that we wouldn't encounter any infection, hematoma, or anything. Any movement easily disrupts it, right? Now we have the revascularization, the phase 3. So there'll be new blood vessel growth, and then it helps the graft to take. This is more difficult in full thickness skin grafting than compared to the partial thickness or the split thickness skin grafting. Okay. Can we move on? Do you have any questions? Right. I think this one should have asked you. This is quite, what are the factors that will cause graft success? So now it means that you have to come in to add on the factor that will cause graft failure, right? So graft success. So adequate blood supply, right? There should be a highly vascularized bed. There shouldn't be any hematoma formation, any seroma formation. There shouldn't be any movement. You said that earlier on, right? There should be absence of infection. And then we have to still maintain effective immobilization. So after graft, if you see a patient and then they are always turning in bed, you have to be careful as to that. Of course, we are not expecting patients to lay in bed for long, but then for the place of the graft, you should ensure that there wouldn't be that excessive mobilization where even the bandaging will be falling off, will be removing and all that. Right. So for them also with the bandaging, if it's the whole limb, it's the whole limb that has to be bandaged. It's not just a part of it. We want to still ensure immobilization. Failure. What do you think are some of the factors that will lead to graft failure? Yes, poor blood supply, right? Oh, there's a question after skin grafting. I didn't see. After skin grafting, when are we supposed to open the wound? Okay, so someone should answer this for us. After skin grafting, I don't know whether I have it in my slides here, but it's better if we don't finish. After skin grafting, when are we supposed to open the wound, please? Please add that on. It's very
Hello,
necessary. We should know that. Yes.
hello.
Yes, yes.
Okay.
With the
Yes.
donor side,
Mm-hmm.
mostly 2 weeks,
Okay.
and the recipient side is 5 to 6 days. You should open it.
Okay. Okay. So basically the donor side after 2 weeks, mostly yes, they were so mostly you see that they even will write because they know that if they discharge the patient, even if the patient is on the ward, before you realize, even though some nurses have nursed these patients for long, but still before you realize they've opened it because we all know that after third day every wound that has gone for surgery or whatever you have to open. And so you see the doctors or the surgeons will even use a pen to write on the plaster and tape it on the bandage that this should be opened on this date. You get it? Yeah. So the donor site is what? Mostly 2 weeks, 14 days, right? And then the recipient site after a week. That's great. Right. So factors for yes, infection, excessive mobilization, adequate blood supply. That's great. That's great. Thank you. So that's just about that, right? So poor vascular bed infection. So that's just about it. That's just about it. Right. So nursing care. Find out also skin grafting harvesting tools. What are they? What are they? We have the skin grafting knives. Please find out, get pictures of that. Find out the use of that. You see, we have
Doctor,
always.
please, can I add a little bit about
Let me finish, please.
hot meter?
No, let me finish. Let me finish. So find out the skin grafting harvesting tools, the skin grafting knives, the skin grafting blades. We have dermatome. Find out what is it and what is its use. Please find out all those things. Right? We have the skin graft measure. What is it? What is it? Find out also. And then find out even how it is done. The application. Is that okay? Just for the knowledge, so that whenever these patients comes in, we know that they are patients that have undergone all these series or stages of grafting. All right. So nursing care, the graft site. Nursing care, the graft site. We know that we have to. No, let me let you come in. I think we have a bit of time, right? So yes, I think for the nursing management and all that, let's see. Donor side, graft side, nutritional support. Okay, so do a bit of nursing care. Let's do the flaps quickly. Can we come in? Nursing care. Do we have some in the chat? Nursing care, nursing management. Yes, I like that. Please raise your hand up before speaking. Yes, we don't just say, and that's mostly what we do. We don't just put off unmute yourself and talk, right? You distract me as well. Thank you, Prince. All right. So nursing care. Nursing management. Can we come in? All right. Find out. What do we do after grafting? What do we do for these patients after grafting? Flaps, skin flaps. What is flapping? What is skin flapping? Basically, flaps are what? Transferring of the skin and the subcutaneous tissue from one part of the body to another part with a very vascular pedicle. What really is pedicle? Or any other attachment to the body that has to be maintained for nourishment. Skin flap. So I'm sure you also have to find out what is even the difference between grafting and flapping. We started with the grafting was the epidermis, right? The dermis that is taken off. This is what the skin and the subcutaneous tissue. So there will be additions to the flapping other than the grafting. That will be transferred from another part to another part for help for nourishment. Are we clear? So a part of the skin, subcutaneous tissue, being transferred or attached to another part. What is a pedicle? What is a pedicle? So mostly with that, a part is maintained and the part is just taken and put over the other. Is that okay? We have large flaps, we have small flaps. Large flaps can be trimmed to become a small flaps to cover up whatever damage we want to maintain. But then small flaps cannot be made larger. It is used when bone or tendon or vessels are exposed. We have flapped the wound. It provides a very bulk and better durability than the grafts. So I've said you should find out what a flap is, right? And what is the difference between a flap and a graft? Please find out. Please find out but when you are reading, you find a free flap. I think that's a bit of a difference. A free flap. But then you find out what is the difference between the flap. How does the flap differ from the graft? And then of course you can also read more of what the free flaps. I don't know whether I have it even in my slides, but you can also read more of that. Okay. Okay, so we have the types, the local, regional, distant, and free flaps to find out, I said. Then classify by movement, the tissue type, and then the blood supply. That is the classification for that. And then we have the free flaps requiring microvascular anastomosis. Okay. So what will be the indications? What will be the indication? Very large and complex defects. Coverage of exposed vital structures and the reconstruction after trauma or tumor removal. Management. How would we manage flaps? If we are done, we still have time. Maybe I'll just explain, or let us also come in the free flaps and then the pedicle. But if we don't have time, then you read that on your own. Management. So post-operative flap monitoring. And so we want to do our hemodynamic checks and stability. We want to observe the flap, the color, the temperature, the capillary refill, even swelling, observe for any venous congestion. We want to monitor Doppler, assessing perfusion. So monitor Doppler if available, right? And then also want to drain output. Mostly for flaps, they put in wound drain. So that one to find out why is wound drain put in flaps, skin flap after skin flaps, why wound drain, right? So that is also monitored. In terms of positioning, it's also the same. We also want to maintain positioning to promote tissue perfusion. For flaps, also limb elevation is also key. We'd want to elevate it to avoid any swelling or edema. And then also, we want to avoid any dependent position for these patients. When you are doing our bandaging, you want to avoid any pressure. It has to be firm, but we avoid any pressure. With the wound drain, we want to avoid any kinkiness, because if there's any hematoma formation, the flap wouldn't hold, right? We want to do that. The limbs, we want to support it with what? Any pillows and all that, right? Complications. You may have flap pedicle necrosis from poor blood supply, infection or hematoma, and then any flap congestion or ischemia. Do you have any questions? Do you have any questions? So what should I touch on again? You have about 10 minutes. Oh, yeah, okay. Please, what should we touch on, or we are okay? All right, we are okay. That's great. That's great. All right. All right. Then thank you. Thank you very much. So enjoy your evening.